Thank you very much. I realise that the time is fairly limited today, so it's going to be quite a quick whip through to allow you a chance to ask questions, because I think a lot of the time the real value is in you being able to get answers to the questions you've brought with you. There's a lot of rhetoric about integrated care, and if you speak to 5 clinicians, you'll get 6 different definitions of integrated care. If you speak to 5 managers, you'll get 26 definitions of integrated care. And so we're hoping to cut through some of that and give you some practical examples of where we have done what we feel to be genuine integrated care. So the question is, what is integrated care? Integrated care has been around for many, many years, both internationally and within the NHS. In Minneapolis, for example, I know an organisation which calls itself an integrated care organisation, and it's run by GPs with a capitated budget, and they manage primary care, secondary care, and community care. Sounds strangely familiar, doesn't it? Anybody think it might be the NHS? Alternatively, also in the US, you've got examples where secondary care hold the budget, and then you've got other examples where the budget is held by organisations on behalf of Medicare and Medicaid, and the integration is done by the commissioner effectively. But to cut through that, fundamentally, when you're looking at integrated care, you need to ask a series of questions. First, who pays? And although that may seem obvious as it being the NHS, it isn't always obvious, because quite often you've got social care involved, you've got the third sector involved, and you've got other people contributing to that pot. Secondly, who carries the risk? And that's the fundamental part of integrated care, is who carries the risk, both clinical and financial. Where does the budget sit? And that's the bit that gets a lot of people very interested. And also, crucially, what does that budget cover? Because I've looked at a number of integrated care models where they look absolutely fantastic on the surface, and then you realise the list of exclusions about what's not included is about twice as long as the actual integrated care proposal. So I like to think of it in terms of a grid, where you have a primary individual who is managing the integrated care, and then you've got all the other players. And if we take the first one of being diabetes, for example, in Cambridgeshire, within the NHS in Cambridgeshire, we tried to set up an integrated diabetes care management programme where secondary care actually would have held the budget for everything apart from straightforward primary care managed diabetes. So they'd have held the budget for the drugs, they would have held the budget for secondary care, inpatient and outpatients, and they would have held the budget for community care. The difficulties with that was arguing the definition between what is core primary care diabetes management and what isn't. So that spent an awful lot of time on that. But in that situation, the secondary care would have been the budget holder and the primary risk holder. If you take acute care management models, then primary care can sometimes be the acute risk holder in that situation, with the budget sitting with the NHS and the commissioner. Again, if you look at long-term conditions, which is such as the one we're looking at here, the commissioner is holding the risk from the budget point of view. And with that, I'm going to step straight on to Rochelle, who's going to focus most of the talk actually on giving you 2 practical examples of where we've done the integrated care.
Hi there. So as Luke was just saying, there is lots of different interpretations of integrated care. I was just advised by Phil that actually the King's Fund reported that there's actually 175 different definitions of what integrated care is, which just shows in terms of the complexity of actually making this a reality. So in terms of for this, I'm mindful we have got quite a few slides, and it is going to be somewhat a whistle-stop tour through our slides. We are on stand I-11 if anyone wants to find out a little bit more, and I know that our slides will be shared across to everybody for this conference. So in terms of our actual integrated care work that we've been leading on from UnitedHealth UK, this started 5 years ago when we first started to work at North East Lincolnshire Care Trust Plus, which is a PCT that was merged with a local authority. And we feel quite fortunate to have spent nearly 3 years with them in terms of helping them get to where they needed to go, to also understand how health and social care actually needed to merge together, and how that then evolved into some of what we do around integrated care. A lot of the stuff that we do is an amalgamation of some of our learnings from North East Lincolnshire and a lot of the work that we've also learnt from the US. For the purpose of today, what I'm going to be focusing focusing on is actually the work at Aerowash CCG, which is a CCG based in Derbyshire. And this slide just gives you a feel for in terms of how many different organisations we've worked with and built a relationship with in terms of actually managing the integrated care. So it's not just a matter of going into a CCG and working with the local authority, it's a matter of the other partners that you need to work with and engage on and build that relationship before you even can start to make the changes that are required around the service provision for integrated care. For what we do, our kind of overall aims for anything that we do around integrated care programs, we manage a number of them across the country. Our overall aims are in line with the National Long-Term Conditions Programme, so Sir John Oldham's model. So very much what we're looking at is the whole piece around risk profiling. So actually, how do you really understand those individuals that are at risk within your community and how do you determine who those are? Another piece is around actually neighbourhood care teams. So actually, how do you look at integrated care teams? How do the health and social care teams need to work together? But who else do you also need to invite from your key partners to be part of that team? And finally, we look at self-care and enabling users, the individuals that are going to be receiving this care, and very much linking up with them to make sure whatever we're suggesting is led by them. Our core three aims for any kind of integrated care project we work on, we've got three areas, one of which is around joined up, so very much in line with the neighbourhood teams. What do those MDT meetings need to look like? Who needs to be involved? Another piece is around personalised, so very much linking in with in terms of healthcare of what does it need to look like, but also from social care, how do we link up with the personalised budgets? How do we make them actually real? And actually, how do we make sure that the individual that's going to be on the receiving end is part of all that process? And the final piece is around prevention and early intervention. So everything that we do is about being proactive. I don't know if anyone came into the QUIP session this morning, but a lot of the discussion was around how do we make sure that actually we are proactive rather than being reactive. And this is very much what we kind of drive through all of our integrated care products. So at Aerowash, when we first started at the programme, or at the CCG, what was really quite apparent was there was lots of different ways to access a system. There was lots of, different ways people were providing a service. There seems to be a lot of individuals going into a person's home and providing very similar services. So when we did an initial analysis of actually what do the caseloads look like and who's managing that, there was a 60% overlap from health and social care of who was managing those individuals. For someone that's an individual with complex needs, that felt to be extremely confusing for a lot of those people that were involved. One of the things that we looked at as part of our integrated care model was, again, how do we introduce that kind of prevention, that early identification of those people that are going to be at risk? So how do you find those individuals and how do you make sure that you actually provide the services accordingly? How do you create something that actually you've got a rapid response element to? The services at Aerowash, when we first started, they didn't have that. They didn't have a function there that actually was able to respond within a certain amount of time if a person was at risk of being admitted to hospital. Another piece was around also treatment and supported discharge. So what did that need to look like? Who did we need to link up with? And what did those pathways look like? And finally, around self-management, follow-up and support. And again, when we looked at, they had these care plans in place across Derbyshire, but again, there seemed to be quite a variance in terms of how they were being used and where, although they were meant to be individual care plans, they were being more used by out of hours rather than the individuals. Quick demographics, not going to go through it in too much detail, but gives you a feel for the context of the CCG. Quite a small CCG, 96,000 population. In terms of the social services, that was broken out into 3 localities. In terms of healthcare, they'd already gone through a process of what do their teams need to look like. So what does that configuration need to look like? 2 main acute providers. Aging population, recognised that there was going to have a massive demand on health and social care. And finally, when we actually looked at in terms of how people felt they were being, managing their own condition, that was quite lower than a national average. It was 12% lower than the national average, which was quite a shock when we first got into the CCG. High level, again, just in terms of the approach that we took, we initially started there as a scoping. So we went in there for a 6-week piece of work. We worked with it. The first thing we did was identify who the stakeholders are. So who do we need to link up with? And we spent those 6 weeks spending time with those individuals. So from mental health trusts, from the acute trusts, from the primary care, from the community providers, from social care, from all the patient groups, and then also meeting up with additional individuals, spending time with them and understanding how services were being provided and what the pathways were to support that. One of the pieces that we were asked to do was around an integrated care model. So actually, okay, we've got all these, we found a lot of information throughout that 6 weeks. We spent a lot of time. So what does that mean? How do you make that actually real? How do you turn that into something that they can actually do something with? So one of the key pieces that we were asked to do was actually define a model in terms of how would they manage their long-term case management. How would they manage people with long-term case management needs, and how would they manage those individuals that actually needed an urgent response, and how do you link up with all of the services that are part of that whole system? So a very small task in 6 weeks. And then the other piece for us, that while we've been at Aerowash as well, was we were then asked to actually support the implementation of that. So that's taken over a 7-month period of actually how do you get all those pathways in place? How do you actually get those teams up and ready? How do you create that integrated care approach? This just shows you, just a governance structure. So for every integrated care program that we introduce, we make sure there is a program management structure to support the whole process. There were 4 key work streams that came out of our initial scoping. There was 4 areas that were seen as a massive, there needed to be a massive amount of work done for it to be enabled to actually provide an integrated care service. One of which was a single point of access. So although they had a clinical navigation service, what it wasn't doing was actually providing a single point for people to go to, and the assurance for those people that needed to refer into the system of where they could go and actually feel confident that that referral would go somewhere, because the services weren't in place for the referral to go anywhere. So they may have had a service, but unfortunately the supporting services that were required weren't in place. Another piece was around what does the community delivery team needs to look like? So what do the teams that are being paired around those practices actually need to look like to provide that long-term case management approach? Another piece, which again we've heard a lot about today in some of the sessions, is around information. How do you get the information between all of these different services and all these different systems that actually talk to each other? So one of the pieces that we've also were asked to do was actually look at what's the data, how do we kind of create a unique identifier where the data could actually talk to each other, and how do we start reporting on that? We are only at the point now where we've created that reporting structure. We're now got reports being produced, but that has taken nearly 9 months to get to that point. So, it's just also being quite realistic of actually this takes such a long time to actually deliver. And then the final piece was around the communication engagement. So not only with the stakeholders, but how do you make sure that you engage throughout with all the individuals that would be receiving the service, and making sure continuously that the service is fit for purpose for those individuals. So I don't know if everybody can see this model on the screen, but basically at the top is the referrer, and on the right-hand side of the model is that long-term case management, which I've described, which is where we had community delivery teams set up to actually provide that long-term case management service. On the left-hand side is that single point of access, so actually which services they could refer into and what the response would be for that. And all of the blue blocks, the building blocks at the bottom, are all of those supporting services that we had to liaise with as part of our scoping, but be part of, as part of the implementation as well, which just shows in terms of the approach that they've taken, and it's quite a whole system approach in terms of how many services they've got on board and where there's, how much effort and engagement is required to do this. So the 4 areas in terms... For the 4 areas in terms of what we've really focused on around the single point of access. So although there was that significant piece of getting the referrals into all of those blue supporting services, it was also what criteria did they actually need to look at? What was the criteria that the service needed to provide? Because again, the service before, when we looked at the criteria, it was done more so on good faith that, a referral came through, if a GP had referred in or a community matron had referred in, it was felt, well, then that was the right referral. Well, actually what we needed to look at was what was the criteria, around what the hours. Again, the service, when we first of all it started, was a 24/7 service, but when we looked at the data, it didn't support the need for that. So again, we reduced the amount of hours required for that service, but instead had alternative services for those referrals to go to if they were out of hours. And we had to also set up a service level agreement. In terms of rapid response, that again, we had to look at resource. We had to shift resource from some of the community provision elsewhere into rapid response. So some of the staff had a dual role. So some would be community matrons or within the community nursing team, and then they would shift over to rapid response depending on what the need was. The community delivery teams, again, that was part of setting those services up, spending time with the practices. And finally, one of the pieces that Aerowash have also done is introduce a risk stratification tool, so actually to determine who are those individuals that are at risk. One of the pivotal step changes, I think, in my view, for Aerowash was the introduction of a care coordinator role. So this was a pivotal role for the community delivery teams, and this is where we really started to notice a change of confidence for those health and social care professionals in the system, where they were able to pass individuals to this community delivery team for long-term case management. And this is where this care coordinator role has 4 functions. Again, happy to go through this later because I'm mindful of time. This is just an example of the kind of implementation plans that we introduce for any of our integrated care programs. And these are high level in terms of actually what the outcomes were. So one of the very first things that we made sure was that actually all of the partners that sat in the room agreed some very high level outcomes, which then fed into what the reporting needed to look like. Thank you. Oh, sorry, I've still got more slides. So this is just very quickly about North East Lincolnshire. I know I mentioned it. It's just important, in terms of Aerowash, it's been very much about setting up the community provision, and we're getting now to the reporting stage. For North East Lincolnshire, because we were there for a significant amount of time, we did set up the reporting. We reported against a number of outcomes. For the first year, we tested what the reporting needed to look like to get people to record in a certain way what those outcomes were and what the associated savings were. Once we felt after that time that people were recording the way they needed to, we were able to report over a 9-month period that there was 1.7 million savings made within health and social care, 1.2 million being acute and the 500k being social care. We always when we talk about North East Lincolnshire, what we've also done recently is gone back there like a year on after we've left and said, well, what's the impact been since we've gone? And they've made a further savings of 4.8 million in the year since we've left. And again, we're happy to share this information. And just in terms of our risk stratification tool, that again was seen as a massive impact for how North East Lincolnshire managed their case management and how community matrons manage their caseloads. And that's just high-level feedback. Thank you.
So very briefly, just to finish, I'm going to talk very briefly about our case-finding tool. Our health numerics tool has 2 aspects to it. One is a risk stratification aspect, which can be done for commissioners using pseudonymized information. But the bit I'm wanting to focus on is the case-finding tool, which is used for direct care. It's based using something called an ETG, episode treatment groupers, which I'm happy to go into given time. I'm not going to explain them in detail, but broadly speaking, they lump diseases together based on the physiological and biochemical process of that disease. So that, for example, pre-diabetes and diabetes are linked together because they've both got the same driver behind them. They're also linked longitudinally with new episodes being considered after a 30-day gap. So if you attend your GP and then you go into A&E and then you get admitted into hospital and then you get discharged to a rehab team, but they're all connected with the same disease and the same acute episode, that's not classified as multiple different episodes, it's classified as one episode of an increasing complexity. So you don't get spurious figures going in there. You get a real reflection of how the patient's journey is happening. We did some research with Somerset to find out, well, not to find out, to demonstrate how effective our tool was. Looking at what the predicted outcomes of our tool were going to be versus what actually happened. So we tracked what the predictions were versus with the real behavior over a period of a year. what we found was that there were some quite interesting things that came out in terms of the drivers for disease, but also we found out that the tool was fairly effective. Now, I'm not a statistician, and when I normally do this lecture, I've got a statistician standing up with me. But I do remember from my dim and distant days as a medical student that a C statistic of 0.832 is pretty good, and the King's Fund defines anything over 0.8 as being very strong for case finding. And there's a little bit more there about the stratification of the case finding predictive values. The other thing I'd like to stress is that your tool is only as good as the last set of data that you put into it, and there is drift on your data analytics. So if you set up a tool that was really effective 5 years ago, and then you don't visit it, it will not continue being as effective 5 years down the road. So one of the questions you have to ask is how often and how effectively your risk algorithms are actually updated. And ours are just undergoing their biannual update, and will be published later this year. So we try and update on a regular basis. And these were the Somerset scores were based on previous algorithms. Obviously, we hope that with the new algorithms, it'll become even more effective with the publication in a couple of months' time. So just a very, very quick whip through. And if you want to see me on stand I11, then I'm happy to chat through that in a little bit more detail afterwards. But I'll open it up to questions, if that's okay.
Hello, do we have any questions? Please put your hand up and we'll get the mic to you. Anybody got any questions? If nobody's got any questions, I'm going to suggest that you go to stand I11 and talk to UnitedHealth there, and they'd be more than happy to give you further information. Please take all your paper and rubbish with you so that we can leave the hall ready for the next time. Don't forget your feedback forms. And let's, in the usual way, say thank you to Luke and to Rochelle.